a few years ago, so it's quite funny realizing that I'm standing here without him. So, okay. Glaucoma. It is a problem which upsets, of course, the patients because we are dealing with the sight, we are dealing with the eye, and there is a danger of losing the sight. So the patients are mentally quite upset by it. And I, in my practice, I did about, I think, 12 until yet, and with very good results. But I didn't do any statistics because I didn't know that I was going to talk about that today. So I can't present you figures, statistics, but well, I can assure you, I will try to show it to you, that we have real big potential with the classical osteopathic stuff. So it's a progressive, irreversible disease, what they say, and that is the question of the eye, in which the intraocular pressure becomes high, with ultimately lead to visual loss and blindness. It results from an increased resistance to fluid outflow. So an increased production of aqueous humor is also a possibility, but it's more a problem with the outflow of the eye liquids. This is a simple schema. And there you see the pressure of the liquids in the eye and giving pressure on the optic nerve, which can starve and lead to blindness. How about the anatomy? The human eye is filled with two fluid-like substances termed humors, which maintain the ocular pressure and maintain as well the shape of the eyeball. We got the aqueous humor, it's a water-like fluid, and that's in the front of the lens. And then behind the lens, we've got more vitreous, gel-like liquid. And the aqueous humor, because it is water-like, gives the possibility that the lens can accommodate to the vision necessity. So thanks to the aqueous humor, the lens can change to look very near to you or far away from you, okay? And the gel-like vitreous humor is more gel-like, and that's really to maintain the shape of the eye, to maintain the retina in its place, and to give also nutritional possibilities to the retina. And then you see that the aqueous humor is a low viscosity fluid, secreted and reabsorbed. So there is this balance between secretion, production, and reabsorption, which is to maintain the pressure in the eye. And the production starts in this area, where there is this production coming from the artery by filtration. It goes into the interstitial spaces, and from that it goes into the posterior chamber, going to the anterior chamber. And then we will see later there are channels to reabsorb this fluid. And in the beginning, until shortly, these channels were considered being venous channels. But elderly osteopaths, former osteopaths, were already talking about lymphatic vessels. And again, it's very interesting to see that the lymphatics in the body were and still are long time not recognized. But they were described by still Littlejohn and others. For example, the cerebrospinal fluid was long time considered as being an apart, distinct fluid, nothing to do with lymphatics. And then recently, 2016, they recognized that there was a lymphatic connection between the cerebrospinal fluid and the lymphatic outflow, a glymphatic. And I talked to a medical doctor next to my door, radiologist, and I asked him, why don't they just say lymphatic instead of glymphatic? And he said, well, they are so proud, so they had to invent something new, which is glymphatic. But Littlejohn talked already about that in that time. So again, if you realize that the lymph is created mainly from a filtration from the arterial blood, which the filtration goes into the interstitial space, and from there it goes free in the lymphatic vessels without any physiological or anatomical barrier, the entrance is directly free. So from that we can learn that the interstitial space fluid is the same as the lymph. And this is a very important item not to forget. Explains a lot of things to us, considering the lymph presence in the whole body. So it's quite funny that they are talking about this filtration of this fluid going into the interstitial space and then flow into the posterior chamber. And then they are talking that there is a drainage. There is the canal of Schlemm, we will see later, and the drainage should be venous. So there is a contradiction. But later, we will see some studies that recognize that there is lymphatic fluid. Okay? And we could say, according again to Littlejohn, of course there is lymphatic fluid because lymphatic fluid is everywhere in the body, and all interstitial fluid, which is also everywhere in the body, is lymphatic fluid. So there must be lymphatic fluid everywhere. Okay? So it's a set of pathologies with creating a high intraocular pressure. And if the pressure rises, the optic nerve axons become compressed at the optic disc. We will see the optic disc later. And the compression of the optic nerves blocks the flow of cytoplasm down to the axon into the optic nerve fibers. The cytoplasm, which is also a kind of fluid, lymph fluid, is blocked. Lacking the oxygen and nutrition needed from the cytoplasm, the function of the cytoplasm, the optic nerve becomes ischemic, leading to the visual field loss and blindness of the individual. Okay? No nutrition, toxicity building up, and, which was not mentioned, we shouldn't forget the pressure of the liquids. You cannot compress a liquid, take a plastic bag filled with water, and you try to reduce the volume, you won't succeed. So if there is too much liquid, which is causing a congestion, it cannot be taken away, then this liquid will create a compression. Okay? Like I said yesterday already, in terms of, for example, the Meniere's disease, we are not about the eye but the ear, is, according to Littlejohn, again a lymphatic compression in the sheath of the nerve. The nerve is in a sheath, and between the wall of the sheath and the nerve, there is lymph fluid. And if the lymph doesn't flow, it might create a compression might create toxicity, biochemical changes, but also this compression, which will disturb the nerve function, creating inflammation, Meniere's disease, the neurology from the trigeminus, and also vascular inflammation, because the arteries are also in the sheath, and also between the sheath of the artery and the artery wall, there is again lymph. Okay? So about the optic disc, it's a round spot on the retina formed by the passage of axons of the retinal ganglion cells, which transfer signals from the photoreceptors of the eye to the optic nerve, allowing us to see. There it is. Here you see the optic nerve, the retina. There is the optic. Okay? So, again, the aqueous humor is synthesized, well, I was not saying, it was in the ciliary body in the former image. The ciliary body, there is the aqueous humor synthesized in 3 steps. First, blood flows, what I said, into the ciliary area. Secondly, the pressure gradient between blood and flow and the ciliary interstitial space, propels the ultrafiltration of plasma into the interstitium. Okay, there we are, plasma into the interstitium. And then plasma components from the basal to the apical surface, thereby synthesizing aqueous humor and pumping it into the posterior chamber of the eye. Okay, biochemical processes and pumping it into the posterior chamber. So again, there is a filtration from blood, liquid going into the interstitial space and then going into the posterior chamber. Then it goes to the anterior chamber. And again, as I mentioned before, it's so important to realize it explains so much to us. Let's remember that lymph is created by filtration from arterial blood. Not always arterial. We saw yesterday that in the liver, which is a huge productive organ for the lymph, the main production of the lymph comes from the blood of the portal vein. There are 2 hepatic arteries giving blood for filtration to produce lymph as well, but the main lymph volume comes from the portal vein. But in all the rest of the body, the lymph is filtrated from the arterial blood into the interstitial space. And people who weren't there yesterday, you should also realize that the liver is responsible for, if you got the last main duct from the lymph before it enters in the subclavian veins and then into the superior vena cava, the thoracic duct, which is the main duct of the whole body, 60% of the lymph in that duct comes from the production from the liver. So you can imagine the importance of the liver for lymph, and also we see later a bit for the eye, of course. So then entrance into lymph capillaries with a membrane with greater permeability than blood capillaries. The entrance without any barrier. The only difference between the interstitial fluid and lymph is the anatomical location. Again, again, again. Okay? And according to Littlejohn, all body tissues are bathed in lymph. There are areas where there is no blood supply. For example, as I mentioned yesterday, the insertion of the tendons on the bone cells via the periost, this is the anthesis. There is no blood supply, but there is lymph supply. So the lymph is also important for not only for detoxification or for our immune system, it's also very important for nutrition. some more anatomical, physiological considerations before we get to the osteopathic treatment considerations. So here you see the eye, the optic nerve, with the optic disc, which is normally over there. Here you see the vitreous chamber with the jelly-like fluid. There is the ciliary process with the production of the aqueous humor, let's call it like that, posterior chamber, and then it goes in the anterior chamber, and there is this canal of Schlemm there, and there as well. And Netter talked about a venous canal, and a lot of scientifics and also osteopaths who were a long time considering that is a venous channel, but it isn't. There are also sheets surrounding the sclera, the dura mater, and there's an agnoid sheet. So there are the meninges, that's correct, meninges are surrounding also the eye and are surrounding the optic nerve, and that's very important again to consider for us in our treatment. So the canal of Schlemm, because it's a very important channel, but because it's there where the outflow occurs. So let's have a look at that one. As I said, often described as a venous channel. And then Andrew Taylor Still already mentioned the importance of the free circulation of all the liquids, blood and lymph for the eye. And Littlejohn stated that the interstitial fluid is lymph, thus the aqueous humor is lymph, and has to be drained by a lymph channel, because there is a connection between lymph channels and venous channels, but from the interstitial space, the lymph won't flow away through a venous channel. That's just not logic. So if we consider that there is interstitial fluid, which is lymph, and has to be flow out, then there must be a lymph channel. Millard, 1922, described the lymph from the anterior segment of the globe, collects in the anterior and posterior chambers, where it passes into the canal of Schlemm, and I didn't continue, sorry, but he mentioned that the canal of Schlemm was a lymphatic canal, Millard, okay? And then they recognized in 2014 and 2019 that there is, in fact, presence of lymph in the canal of Schlemm. So we are in the beginning of osteopathy in 1922, and it was ignored until about 2014, you see? And then also they mentioned the importance of lymphatic system. You see, lymphatic. No, it's not lymphatic, it's glymphatic, something new, huh? Totally different, okay? For the etiopatogenic hypoptosis of glaucoma. So they already saw that recognized that there is a connection to impaired lymph fluid and glaucoma. And that is interesting. They also in 2018, Grünzig and Hollmann confirmed also the presence of lymph in the anterior and posterior chamber, drained by the superior cervical nodes. It's becoming interesting for us, doesn't it? As well in the vitreous body, which is gel-like, because in literature you will find that in the vitreous body, in the gel-like liquid, there is no presence of blood vessels. So it has to be lymph, and that was recognized by Grünzig and Hollmann. And in the bulbar and retrobulbar space, we see that later, drained by the deep cervical nodes. So the cervical nodes are already, for us right now, important for the pathology of glaucoma. There it is. And then they also stated Killer, Lang, and Grosscott, 99. The presence of lymph in the dura of the human eye, thus confirming Little John, and still that the meningeal membranes, fascias, which are fascia structures, aren't they, are filled with, again, lymph. Okay? And also, lymph circulates between the subdural and the subarachnoid cavities. So if you have the external sheet of the optic nerve with its dural sheet, and the internal sheet of the optic nerve is the arachnoid sheet with spaces, there is going through the sclera, which is conjunctive tissue, giving the mechanics support of the eye. It's conjunctive tissue. There is a passage of lymph from the dura to the arachnoid space. So again, there is a lymph presence everywhere, actually. So the lymph, and thus is omnipresent, and thus plays a huge role in cleansing the eye. As we know, lymph does clean, maintaining a correct fluid balance and nutrition. Considering this anatomical phenomena, it's actually logic that the importance of the lymph is well there, isn't it? Huh? Here you see a bit better the optic disc, and here is the dura, and the arachnoid sheet, and that's also a problem, according to my experiences, actually, that we are talking about the outflow of the lymph in the canal of Schlemm, but we shouldn't forget that here is the dura starting already. So the meningi are there, and they are following the optic nerve, and there is the sclera, which gives the mechanical support. So if there is a lymph problem, an outflow problem from the lymph, there will not only be hyperpressure in the anterior chamber, thus creating hyperpressure in the posterior chamber, thus creating pressure in the vitreous body, thus creating the pressure on the optic disc, but that's what we see in the literature. But according to me, I'm thinking that there must be also a danger of congestion in the dura. Of course, because it's also filled with lymph. And the dura and the sclera and the subarachnoidal spaces are also filled with lymph, which should also be able to flow away. If it doesn't, we don't have only here pressure on the optic disc, but we also get pressure on the side of the optic nerve, the compression of the nerve, like Meniere's disease, like herniated disc in the lumbar spine. The problem of the nerve root irritation is not so often the material of the disc which came out and which is disturbing the nerve root, rather than the presence of lymph, because there is an inflammatory process going on. So there is the efflux massively of lymph in the channel, in the intrathecal channel. And because of the sympathicotenia, with the hypertone of the muscles, all the tissues, the lymph gets to the place where the disc is herniated, but cannot be removed, and will create a compression. And it's more actually the lymph creating the nerve irritation rather than the real herniated material. So if we can free the lymph circulation, you will see that, for example, the reflexes will be restored. Okay, so that's my same thinking, which is not mentioned in the literature, about my hypothesis actually about the compression to the optic nerve from the fascial sheets. Sounds, I would say, quite logical. Do you agree? Okay, the nerve supply of the eye, which is interesting for us. Here you've got the oculomotorous nerve, but what more interesting is for me, that's the parasympathetic nerve. And this here is the ciliary ganglion, which comes from the cavernous plexus, which comes from, there it goes, here, the internal carotid plexus, which are the sympathetic branches accompanying the internal carotid artery, building the internal carotid plexuses, cavernous plexus, ciliary plexus, with the sympathetic action on the eye. And these branches are coming up right from the superior cervical ganglion. The fibers from the superior cervical ganglion will create, surrounding the carotid artery, they will create the carotid plexus and then right up to the eye. Here you see the superior cervical ganglion. There are the nerves going, and there is the carotid plexus, and then it comes to the ciliary ganglion right to the eye. So there again, we've got the lymphatic outflow, which considers us, and we've got the sympathetic connection, of course the parasympathetic as well. But mostly the problem is a hypertony of the sympathetics. So that's why I'm talking a bit more about the sympathetics. So we have the sympathetic superior ganglion connected to the ciliary ganglion, and not to forget that the superior sympathetic ganglion is also connected to the inferior stellate ganglion. And there we have very often the starting point of problems from the stellate ganglion up to the superior cervical ganglion to the ciliary ganglion. And also to realize that the stellate ganglion is at C7, where there is also tissue connection and nervous connection with the last station of the lymph, the angulus venosus, where all the lymph from the thoracic ducts, the left and the small right one, from the jugular channels and from the axillary channels, that will all come into this area, angulus venosus, where it goes into the subclavian vein, and then vena cava superior. So this area where there is the stellate ganglion, it's a huge important area, and of course it's also the base of the neck. So in our posterior posture considerations, you see what's happening over here. So there is an irritation on the stellate ganglion, and there is also an irritation on the lymphatic flow. So there we got the combination of neurological irritation, circulatory irritation, and posture stuff. So that's all what we are doing, aren't we? So that gives, or that should light you up, that we have thus the tools to deal with this pathology. Here again, the autonomic nervous system. There is this is a sympathetic chain and the parasympathetics. So here we see again the superior cervical ganglion giving the internal carotid plexus, and then right to the ciliary ganglion, and then right to the eye. And then of course all the parasympathetics with the ocular motilus nerve, the fourth and the sixth. And of course the importance of the trigeminus in our treatment for all the sensitivity in the orbital space and so on. Here you see again the lymph outflow of the eye and the surroundings. So this also, and there is the subclavian area where the lymph is drained into, is also again explaining us the importance of our osteopathic lymphatic treatments for the eye. And you saw the techniques showed by Chris Campbell yesterday, which gives you wonderful tools to give some. There are other techniques as well, of course, there are so many techniques. But with those techniques you can already think that you're handling a part of the lymph outflow from the eye, okay? So let's come to the osteopathic treatment. So far, okay with you? Do you have any questions? Was I quite clear? Yes. Yeah? Okay. So again, the Dr. Still and John Mark Littlejohn mentioned the importance of the vasomotor nerves between T2 and T4. They mentioned the importance of the lymphatics C6 and C7, T1 and 2. The clavicles, of course, for the freedom of the angulus venosus flow. And C1, 2, 3 in relation with the SCG. And then here C7, 6 and 7. Little John mentioned it as well. I don't know why I didn't write it down, but the importance, according to Little John, of the presence of the stellate ganglion, which gives the branch right upwards to the SCG. Okay, don't forget that. And of course, as classical osteopaths, the importance of the thorax, the freedom of the thorax for our osteopathic centers, for the vasomotor centers T2, T4. Diaphragm, we saw yesterday, and those who were not there, please do realize that the diaphragm, so I mentioned the importance of the liver for the lymphatic flow in our body, and also the importance of the diaphragm, because even nowadays, if you look at the lymph schemas, then hardly you will find the liver mentioned as a lymphoid organ, actually, neither the diaphragm. They will show you the thymus and the bone marrow as primary lymphoid organs, and they will show you the spleen, the mold tissue in the intestines, the adenoids, the tonsils as secondary lymphoid organs, storage organs, but you will hardly see a liver or a diaphragm mentioned, which is quite strange, because you know that the diaphragm is the big pathway from the sataena chyli, draining all the lymph from the legs and the pelvic floor and the abdomen, going right into the sataena chyli in the diaphragmatic fibers, and then it goes into the thoracic duct, and also the peritoneal fluid and the pleural fluids. These are flowing free into the diaphragm, which is huge, actually a huge sponge. And according to Littlejohn, the diaphragmatic activity is to be considered as the main lymphatic pump from our body. A question? 5 minutes. Oh, okay. So, and then of course the connection between the diaphragm and the cervicals by the phrenical nerves. Huh? And then what is often and more often nowadays as well, the importance of the pelvis, the pelvic organs with congestion and the pelvis dysfunction, which is the base of our total spine. And the pelvic congestion will also create a congestion upwards in the cranial area. So my trainees are able to start working. They are from the Swiss University, working on a shoulder problem. They're treating with the neck problems and the thoracic problems, but they won't touch the pelvis anymore. So there was this osteopathic thesis in 2006. She found, an osteopath, she found a positive effect on the intraocular pressure, about 10% improvements after 3 sessions improvement of the pressure, with treatment principles, cervical dorsal area, OA, venous sinus, CV4 technique, cranial techniques, venous lymphatic pump, and neurovascular integration of the eye, inhibition of the cervical superior ganglion, body statics if necessary, only if necessary. Van der Kraats did also an osteopathic thesis. She worked with the recoil techniques in 8 units. I don't know what it really is, but well, anyway. And she found an improvement of also about 10%. 10% improve in the getting down the intraocular pressure after 3 osteopathic treatments. And these were they were speaking about lymph in general, but they considered as well the canal of Schlemm as lymphatic, as a venous channel again. So as I told you already, when we are treating, we should consider the posture, posterior posture or the anterior posture. You can see the tension on the pelvis and of course on the CD and OA. Quite obvious, isn't it? The triangles of force. So how can we forget the pelvis if you just consider the importance of the triangles of force L3, D11-12, C7, T4, sorry, the pathway, the crossing pathway between the upper triangle and the lower triangle, with the importance for C7 and of course OA region. And there you see what's happening with a twisted pelvis. You see the change of the lines of force, having the derangement, the obstruction in the OA, and then again right to the eye. So, lymphatic decongestion, the main aim, thanks to the body adjustment. And thanks to the body adjustment, we can deal with the sympathicotenia, because if we want to free the lymphatic circulation, we must calm down the hypertonus of the sympathetics to get a vasodilatation instead of vasoconstriction, to release the tones of the tissues, obstructing the pathways. So we have to deal with the sympathicutaneia, and therefore the body adjustment gives us good possibilities. Inhibition of the inferior ganglion, of course, ciliary ganglion, eye posture, eye and face treatment. Again, Chris Campbell mentioned, showed yesterday some techniques, wonderful techniques where we can reach via the trigeminous and the facial nerve centers, we can reach the vagus nerve because they are connected with the nucleus from the vagus nerve in the solitarius tract in the medulla oblongata. And don't forget the liver, of course, because there is a liver importance for the lymphatics, for the eye, and also, again, what was mentioned, the psychophysiological unit. And the liver can easily store emotions like anger and injustice. And then you've got the lung field which could store the emotions of sadness. And if you take the medal, the emotional medal from sadness, you can easily turn it into anger. And from anger, you can easily turn it into sadness. It does not have to be there, but it can be there. And I was once, a few months ago, I had a situation that somebody caused me a big deal of injustice, and in the same evening, my right eye was totally red because of the hyperpressure. Thanks to my liver pressure of the knowing of the injustice, whop, right to the eye. Okay? Diaphragmatic respiration gives me a lot of release from it. So we started with Little John, that all the body tissues are bathed in lymph, and I wanted to end up with still, if we think and say that disease is only too much dirt in the wheels of life, then we see that nature takes this method to wash out the dirt. Let the lymphatics always receive and discharge naturally. If so, we have no substance detained long enough to produce fermentation, fever, sickness, and death. We strike at the source of life and death if we go to the lymphatics. Thus, it behoves us to handle them, the lymphatics, with wisdom and tenderness. For by them and from them, a withered limb or any division of the body receives what we call reconstruction or is built anew. And my patients I was treating, they don't have any medication anymore. They are free from medication, and the eye conditions, which are followed each 6 months, are stable for the moment. No statistics, I'm sorry, but it is there. So that was it. Thank you.
Wonderful. Thank you very much, Hendrik. That was fantastic. We do also have a course that's run by Hendrik in September, which is going to be at Peace Lake. We ran it in Dublin in December.
So just a tip, when you are in front,
try
not to be where he was. All we can film is people coming out in and out of the door.
Okay, it's right down this side.
So just stay over here in front of the
I could
people.
stay here.
See where this is?
Yeah.
That's the border. Otherwise people can't see you.
If you are interested,
I want us to let you know when you've got 5 or 10 minutes left.
What?
I want us to let you know when you have 5 or 10 minutes left.
Oh God, yes.
Yeah?
Because
and obviously the
probably
other
got it. Yeah.
main sort of course is the postgraduate diploma in classical osteopathy, which is starting again in September. So if you have any interest in that, there's brochures on that. You can also let Sean know or book one here. But we only have up to about 16 places, so because we like to run small groups. So next up, we have Chris Campbell, who I'm sure you're all aware of. Chris is the world's leading expert on traumatic neurology.
God, what a title.
Osteopath. And he's going to be talking about the principle of osteopathy as an abiding truth, the comprehensiveness of which we have not yet begun to realise, and explore it in relation to the fragmentation of osteopathy on the basis of technique. So, osteopaths these days are often like to be described apparently by what technically is artificial.
Oh, I'm not going to be able to read anything here.
So, once we've got the technical bit sorted out, I will hand over to Chris Campbell.
So nobody can read that, huh? All right. Why should it be like that? It shouldn't be like that. So come out of that and do it from here. Oh, and they still can't read it. You might have to turn the lights off. Oh. Anyway, they don't have to read it. I have to read it.